Okay. Good evening, hi everyone. I'd like to welcome everyone to tonight's SMRC webinar, Radiology Review. My name is Jessica Sher. I'm a PGY4 in the rehab program at UW in Seattle, Washington. I'm going to HSS in New York City next year for my sports fellowship, and I'll serve as your moderator tonight, as well as a brief Q&A afterwards. During the webinar, please enter your questions in the chat and I'll read each question during our Q&A segment at the end. So now it's my pleasure to introduce our speaker tonight, Dr. Joseph McGinley. Dr. McGinley is a highly accomplished diagnostic radiologist and entrepreneur based in Casper, Wyoming. He is the owner of the McGinley Clinic, where his practice specializes in musculoskeletal radiology and sports medicine, with a particular focus on non-surgical treatments for sports injuries. Dr. McGinley holds both a master's degree in mechanical engineering and a PhD in physiology. After completing medical school at Temple, he went on to finish his residency and fellowship at Stanford University. In addition to his medical career, Dr. McGinley has had an impressive portfolio of over 130 patents. He is the founder and CEO of McGinley Orthopedics, a company that designs and markets orthopedic medical devices, including the innovative IntelliSense drill. He also serves as the president of McGinley Manufacturing, a custom machine and fabrication shop. Dr. McGinley is passionate about advancing medical education and offers courses to physicians through his company, McGinley Education. Outside of his professional life, he is an avid adventurer and mountaineer, working towards completing the 7 Summits Challenge. He resides in Wyoming with his wife, Diane, and son, Charlie. Dr. McGinley, the floor is yours.
Thanks, Jessica. Appreciate the introduction and welcome everyone. Tonight's presentation, I'm going to go through radiology both on the diagnostic and interventional side. I'll have a couple points along the way that I'll pause. If you have questions, we can clarify anything that has been reviewed. And then at the end, I'm willing to stay on as long as needed to answer any last questions on any of the topics we've covered. Or if I've missed something or overlooked something that you're interested in, feel free to ask and I'll do my best to answer it. So Jessica, with that, I'm going to share my screen and we'll get into the slides for the presentation this evening. All right, so I'm Joe McGinley, founder and CEO of the McGinley Clinic. And on the side there's the shot of our office. One of the things I'm most proud of are the patents. You can sort of get a view of those hanging on the wall, all those plaques. So we have almost 140 patents at this point, and really my passion is education and innovation. You know, in addition to what Jessica mentioned, I used to be part of a private practice in radiology. I now have my own practice that I've been part of for the past 5 years, and we've been growing rather quickly. I was an adjunct clinical instructor at Stanford for quite some time, and I'm currently an instructor for University of Washington as well in radiology. I was past president of the Wyoming Medical Society, so our state medical society, and I was president of our county medical society for several years as well. So I really do enjoy education, I enjoy teaching, and I enjoy academics, even though we are in central Wyoming. That doesn't always go together. My interests really overlap over time, so I started as an engineer. That turned into research in biomechanics and orthopedics. I worked with Dr. Scott Cozen, who's a world-renowned hand surgeon out at Shriners in Philly. He got me interested in research and becoming a physician. So from there, I transitioned into the MD PhD program at Temple. I continued my research actually in cardiovascular imaging and physiology at that time. Finished med school and went out to Stanford and was out in the Bay Area for probably about 7 years. I did my residency out there and I did a fellowship in cardiovascular as well as musculoskeletal imaging. When I went into private practice, that's when I became an entrepreneur. I just continued to ask questions, and all of this stuff built upon itself, resulting in what we have right now. From our medical standpoint, these are our companies that are all integrated. If you come out to our facility, we have a full integrated sports medicine building. We have a 40,000 square foot building that hosts pretty much everything from start to finish in orthopedics. My clinic focuses on interventional procedures for essentially interventional orthopedics. We have a full imaging center with some of the latest technology. Because we're private practice, we get access to stuff a lot earlier. So we have a full imaging center with some technologies that really are only available at a handful of institutions. We have a walk-in orthopedic urgent care, and then recently we started a full orthopedic surgery practice with orthopedic surgeons. We have PT in our building, we have functional medicine, so really a full roundabout way of treating patients in sports medicine and orthopedics. For my clinic, it's patient-centered orthopedic care. We're very careful in the way we use those words. This is, again, interventional orthopedics and orthopedic care, where I'm not a surgeon. So we have minimally invasive treatments for pretty much most things in orthopedics can be done through minimally invasive approaches. So I just listed, just a handful of things that I can do with patients wide awake, sitting comfortable in our office, no general anesthesia, no stitches. So people ask, what's the line between surgery and intervention? For me, I'll tell them none of my patients get sedated and none of my patients get stitches. So that's pretty much the line. So if I can do it and check those two boxes, it falls in my category. If those boxes need to be checked, I'll have them see one of our orthopedic colleagues. But with the advancements in technologies, both in imaging, and imaging really is the driver of this, moving things to an interventional approach, as well as the technology. So if you go to traditional orthopedic conferences, walk around the exhibit hall, you'll see all the new products that are out there to treat orthopedic problems in an interventional manner. This happened in medicine probably about, 20, 30 years ago in cardiology, right? So back probably when I was in med school, cardiac surgeons were, the sort of the king of the castle. And if you had a cardiac issue, you would go right from the primary care doc to the cardiac surgeon. Really, cardiologists weren't that significant back then. And then the technologies developed that made cardiology, and specifically interventional cardiology, the prime focus. And now, they can do valve replacements through interventional cardiology. We're seeing that same revolution in sports medicine, and you're all part of it. It's, this is not specific to radiology or anything else. This development is growing rapidly across multiple specialties, and it's really exciting to be part of this change in medicine. This is just some of the stuff that we've been covered in. I've been in Runner's World, Women's Running, Motocross magazines. It's been pretty cool to be part of a lot of this. We are the official orthopedic provider for pro motocross, so if anyone's a motorcycle or motorcycle racing fan, we are becoming the prime motorsports orthopedic practice. We're going to be with IndyCar this year, with Andretti Racing, with Lockheed Hughes, with Indy Next, and we recently partnered with the privateer program for motocross and supercross. This is what our race team looks like. We're just sponsored and work with the riders. We're not owners of the team, but pretty cool to be part of that as a radiologist in developing sports medicine. So now we're going to get into specifics of imaging, and what I'm going to talk about in order is X-ray, CT, MRI, and ultrasound. No matter what specialty you go in, you're going to be using, or at least ordering, any or all of these on a daily basis. As prices come down and this gets more economical, it's really, and the technology improves, imaging just becomes more integral in the diagnosis and treatment of patients. So let's start with X-ray. This is the most common. Everyone that comes to my practice gets an X-ray, every single patient. It's just a lot of information, very inexpensive, safe overall. So understanding the different modalities is really key to the success on picking which one and when. So indications for use is always a challenge for people, especially if you don't have a radiology background. So when do you order, an MRI versus a CT, or a SPECT CT versus a CT myelogram, or ultrasound versus X-ray? Those are challenging questions if you're not familiar with imaging. So if you understand the way the imaging works, or at least in general what each modality does, it'll help you decide a little bit more clearly which one to pick and when, and what's most appropriate for your patient and their specific problem. Sometimes it's not clear. Sometimes you need more than one. Sometimes you need both. Sometimes you pick one and you pick the wrong one. You got to get another one. That's medicine and life. That's the art of medicine, I guess I should say. But in general, I'll try to break it down for you so you understand the basic principles, and then that'll help to decide what to get. For orthopedics or sports medicine, like I said, 100% of my patients get X-rays. It's just there's lots of information there that it helps me in the decision making. It helps me eliminate some major problems that can occur, and it's very easy to do and obtain. So for X-ray, it essentially uses electromagnetic radiation. So X-rays penetrate matter based on density absorptions. So with X-ray, you're looking at differences in density. So on the right side of the screen, this is a sagittal view of a wrist X-ray in a patient with a fracture with a plate in place. So you can see various densities on the material. The darkest, the blackest area, that's going to be the most dense material. That's the surgical hardware. That's the titanium plate in this patient. The next greatest density are the sort of the grayish dark structures. Those are the bones. Those are the carpal bones, distal radius. So bones are dense, they're calcium-based dense. And then you sort of get into the lighter gray structures, that's the soft tissue. So for X-ray, the darker the identity on the X-ray, the more dense it is. So that's the correlation. So differential absorption, dense material, bone absorbs more X-rays, and softer tissues don't. It passes through. So X-rays are generated by accelerating electrons onto a metal target, so that's the receiver on the back side, and then it's radiation that's creating those images. So image formation is captured by detectors, creating a contrast-based images of internal structures. So again, density for X-rays is what you're looking at. Conventional X-rays, standard two-view X-rays, that's what you pretty much get for most cases. Fluoroscopy, that's a form of an X-ray, that's real-time imaging for dynamic studies. So just think X-ray in real time. So now you have a live X-ray beam coming and then you can manipulate the anatomy. Still, the key of that is it's only two-dimensional. So remember, with every single one of these images, no matter how many planes you get, they're still two-dimensional, and anatomy is a 3D structure. So you have to keep that in mind, specifically with surgical hardware, because you can get an image like you see on the right side of the screen, and all those screws look pretty good. They look like they're in bone correctly. However, if you get an angle on that of 45 degrees, 2 or 3 of those screws could be a centimeter or 2 into the soft tissues and not even in the bone. I have hundreds of those type of images and have seen it many times, so just be aware of that. If you need to see something in 3D, now you're sort of graduating from traditional, planar X-ray to computed tomography. And with CT or computed tomography, it produces a cross-sectional image using a rotation of an X-ray source. So instead of just one source sending a beam out, it's now rotating around the anatomy, still extruding X-rays to get the images, but you get a full volumetric view. Digital radiography, that's pretty much what most places use now. It's digital sensors, faster, higher image quality. And I know not relevant really for this, but mammography is low-dose X-rays for breast imaging. So that sort of rounds out how X-rays are used in radiology and the different modalities. When you're doing X-rays, again, safety is key. You want to always use the lowest dose of X-ray to get the information you need. That's very important for children and kids. So sometimes the density, the clarity of the image may not look as good as others. And a lot of times you're just trying to reduce the radiation exposure, especially in kids. So keep that in mind. If something looks a little funny, talk to the radiologist if you're unclear of what you're looking at. These applications really are across medicine, dentistry, industry, security. You're seeing X-rays being used really across the board, but as always, you want to limit the amount of radiation. This is what a typical X-ray machine looks like. This is the latest machine from Siemens. We were one of the first in the country for this. This X-ray machine is semi-automated, so you see the standing board on the left side. We do a lot of biomechanic assessments, so we'll have patients stand along that board, and then this thing will automatically take standing images all stitched together, so you can measure angles of the pelvis, you can measure the spine for scoliosis, you can measure leg lengths, all done pretty much within seconds. This machine will scoot down and get all those images and put them all together. So this is a full sports medicine package X-ray from Siemens, and this is what that would look like. So this is your standard table where you get traditional X-rays. This is the generator up top, and then on the left side, that's a standing board that you could stand against, and then that plate behind there slides up and down. This generator will then turn sideways and take those images. So you can get both traditional images on the table and standing images weight bearing at the same time. So weight bearing is key in sports medicine. You always want to make sure that you're trying to stress the patient in the most natural way to get the information you need to answer your question. So for CT, it uses X-ray. It absorbs the X-ray variably, so denser tissue, bone absorb more. Rotating X-ray source captures those images, then you can reconstruct in 2 or 3 dimensions. What people don't often realize is if you get a CT, with software now, you can actually recreate an X-ray because you have that 2-dimensional data as well. So if you have a CT scan, you don't need an X-ray as well. With 3D imaging, you can actually literally create an X-ray from the data you already have. Density is typically measured by Hounsfield units. That tells you one density material for another. We use that when we're measuring, especially if we're looking at a mass, like a soft tissue mass. We'll measure Hounsfield units. If we're looking for blood, we'll measure Hounsfield units as well. So the higher the Hounsfield units, that's closer to bone. Lower Hounsfield units, closer to air. So that's essentially the density difference that it's measuring. Helical scanning, this pretty much is what most do, so multi-detector CT helical scanning. So it has a continuous rotation and scans through within seconds the entire body. Images are then converted through algorithms and image reconstruction. AI is a big part of this now. We're seeing more and more of this in imaging, and most machines are including AI as part of that. Contrast, when you use contrast, that's typically if you want to look for enhancement of soft tissue masses. For bone, usually not as relevant with CT, but for soft tissue masses, that's when you're looking for contrast. If you're looking at blood vessels, so if you want to evaluate blood flow to a structure, also you need contrast for that as well. So that's really the main times you do that. Slice thickness is important, especially if you're looking at resolution of small structures. The thinner the slices, the more resolution detail you have, so spatial resolution. And then you can always reconstruct those images. So once you have thin data sections, you can reconstruct in the 3D however you like. So, you know, if you get a 0.3 millimeter thick slice, your eyes might see it as a little bit grainy. So if you don't like it, you can always take it and make it 1 or 2 millimeter slices. It's very easy with 3D software to pretty much generate whatever you want once you have that source data at a thin slice. Pretty much every scanner now is multi-detector CT. All the scanners are getting into the 128, 256 scanners at this point. So it's pretty impressive how quickly the technology is advancing. And then the 3D software for rendering, that's getting easier. You can have it on your laptops or phones now for 3D rendering of images. So it's pretty impressive how fast that's going. And with AI, this is only going to accelerate in the next few years. So what we have now is going to look primitive probably to what we have 5 years from now. So applications for medical diagnosis, you detect diseases in soft tissue, brain, heart, lungs, abdomen, bones. Cancer staging, you're looking for lymph nodes and distant spread of cancer. Trauma assessment, identifying fractures. We just had a case yesterday, one of my PAs got a crush injury on a hand. On the x-ray, he saw a fracture of one of the metacarpals. He said, yeah, carpal bones look a little bit funny. He said that it looks like one of the other metacarpals look funny. I said, once you start saying that, this is ending up in surgical planning most likely. I said, get a CT scan. When he got a CT scan, there were 7 bones fractured in that hand and wrist. Even when I looked at the x-ray, I saw maybe 4. But when we got the CT scan, there was over 7 different fractures, which helped for planning and treatment planning for that patient. So CT can be very helpful at looking at fractures when you're uncertain on an x-ray. X-ray is good for screening, but if you need exact data, especially for treatment or surgical planning, that's where CT becomes important. Procedure guidance, we use CT frequently, especially when we're doing spine procedures and spine injections. It aids in minimally invasive surgeries and biopsies, and is very helpful at seeing the anatomy clearly, especially where you're around critical structures. You want to make sure you know where that needle is at all times. And obviously, industry and research purposes, again, this is growing quickly. So finally, MRI. MRI is essentially magnetic field alignment of protons. That's a little bit different than CT. So CT uses radiation, MRI uses a magnetic field. MRI mostly used for soft tissue. So in general, if you had to say generics, the CT more for bones and solid organs, MRI more for soft tissues. So if you're looking for an infection, if you're looking for ligament injuries, tendon problems, tendon tears, MRI is going to be the better way to go because you'll get a better visualization of the soft tissues. You can't really see that on CT. So with the magnetic field, the protons get excited in water. A radio frequency pulse sort of realigns the protons, and then you'll get a signal detection and relaxation, a receiver essentially, that'll measure those flips in the proton excitement. You'll then get that encoded and then image reconstruction from those signals coming back and forth from those tissues. That's where you get your image. Our current machine uses AI for that, and it's just incredible the new images that they're getting using extrapolation of data using artificial intelligence. These are just some of the more key concepts in MRI. I'm not going to go into this in too much detail, but I'll put it here for you to take a look at. T1 and T2 are the general terms that you would use. T2, when someone says it's T2 bright, that means fluid. So when you think T2, think fluid. T1s, you're looking more just the generic bones and soft tissue. There's different pulse sequences. That's how the signals are being sent out and received. So there's different pulse sequences to determine exactly what you want to look at an MRI. And then just like CT, there's the options for contrast. You can do MRA imaging. You can do contrast injections for looking at masses and enhancement of masses. Also similar to CT, you have slice selection and different volumetric. You can do volumetric scanning now, and then reconstruct in multiple dimensions. So MRI is getting better and better at better spatial resolution and thinner sections that you can then reconstruct in any plane that you want to look at the problems. So that's MRI compared to CT. This is what that looks like on the top right. This is our Siemens MRI machine. This is the newest one that they came out with. It's a lower field strength. So, you know, in the past 10, 15 years, MRI was moving to higher and higher Tesla field strength. So, you know, they started with low field strength scanners, 0.5, 1.0. Then 1.5 Tesla became the workhorse. Then a lot of places are getting 3 Tesla. Then you'll start hearing 7 Tesla. But it's actually flipping back now. So what Siemens did, the scanner we have, believe it or not, it's a 0.55 Tesla MRI. And I couldn't tell the difference in the images between that and a 1.5 Tesla scanner. Now, the benefits of that are you can get these in the office a lot easier. It's a lot larger bore diameter, so the patients are not as claustrophobic. And now you can reconstruct the images using, again, AI embedded technology with a lower field strength scanner, so it's safer for the patient. If they have hardware, this is less problematic. You get less stimulation, less sort of the dizziness sensation being in the room with the lower field strength scanner. So the patients like it a lot more. So it's interesting. It's sort of peaked, and now the companies are moving to lower field strength scanner with technology to make the images look better. So this is what that looks like in practice at our office, and yeah, this has been really well received. One of the biggest things is our scanner versus a traditional open MRI scanner. So when someone says open MRI, it's not really open, right? You got to get the images, you have to have a magnet around the person. So if you look at that sort of that second piece of the image, that's what the area would look like if you were in an open MRI scanner. So it's really just, you know, a top to bottom scanning piece, but it's open from side to side. So that's what they consider open. But if you look at the new larger bore scanners, if you have an 80 centimeter bore scanner, it's actually significantly more open than a traditional open MRI, and the image quality is exponentially better. So we're seeing a lot of patients move from what they used to consider open to these new larger bore scanners, and you're getting better image quality in real time. So this highlights the area of the patient in those scanners and how much space they actually have. All right, last imaging modality, ultrasound. I use ultrasound pretty much for 99% of the procedures I do. I have my PAs and NPs using ultrasound for diagnosis in real time. It's really incredible what you can see now with ultrasound in real time, and questions can get answered that really you couldn't before. This is very important in sports medicine because a lot of sports problems occur in a dynamic scenario, right? It doesn't. Oftentimes, if you're laying flat in bed, things don't hurt. And how do we scan patients, right? We put them in an MRI and CT laying flat. So you can't really replicate the pathology when they're in the most comfortable position possible. So with ultrasound, it's great because if a patient comes in and says, hey, when I do this with my arm, it hurts, I do some weird move. You're never going to be able to scan that on a traditional scanner. So if you get ultrasound, you can put it on, say, okay, where does it hurt? They'll point to where it hurts. You put the ultrasound on and say, okay, do whatever weird thing you're doing with your arm, and then watch. And it's amazing what you'll find and how it's replicated on ultrasound. Patients like it as well because, you know, even though they can't see what you're looking at on the screen, if you point to stuff, they're like, oh yeah, I can see that. And they feel like they're integrated in that care. So ultrasound's really a wonderful tool to use in real time. I would encourage you, if you're not using it, to get used to it. This will be a key part of sports medicine for sure. If you're not using ultrasound in sports medicine, you're really doing a disservice to your patient, in my opinion. So as far as techniques and applications, there's different modes. So there's B mode, that's the traditional gray cell imaging. You can look at blood flow with Doppler, echocardiography if you're in cardiology. Also being used really across the board for abdominal imaging, breast, OB-GYN, vascular. The visualization with ultrasound is just improving, and it's getting smaller and smaller. Advantages: it's safe and radiation free. Out of all the modalities, ultrasound is the safest by far. It's suitable for all patients, even pregnant women. So ultrasound's safe across the board. It's real time, so it's the one where you can do dynamic assessment of organs, musculoskeletal structures, blood flow, and you can see that interaction, which is key to diagnosis. It's also portable and affordable. They make some that fit in your pocket. You can easily, the little bit more advanced ones, you can roll from room to room and just get great, incredible imaging. And then you have the patient as part of that experience, which they really do love. The machines are, probably the least expensive of all the imaging modalities. So I'd encourage you to, if you're going into sports medicine, to learn ultrasound. It's going to be key for your practice for years to come. Okay, let's get into ordering of imaging. So this is important. So what are the do's of ordering of imaging? If you have an acute orthopedic injury, they need an x-ray, period. I mean, that's just going to be standard for a lot of this. For fluid collections, hematomas, palpable masses, and lumps, ultrasound is very helpful. Again, as I mentioned, it's safe. You can roll it right in the room as you're seeing the patient. Just put it on the patient. See if it's a simple fluid collection, if they have active bleeding, if they have a solid mass. DVT, this is the standard of care for deep venous thrombosis. So again, very easy to do. You just put it on the blood vessels, see if there's blood flow, see if there's compression. You can make that diagnosis rather quickly. You can repeat x-rays for fracture management. So if you're unsure, so if you think there might be a fracture, it's not displaced, or else you'd probably pick it up. You have two options. You could treat the patient in a conservative manner, brace them, splint them, have them come back in 7 to 10 days. By then you'll start to see the bone healing and it'll show up on x-ray. If the patient is an athlete and they want to know if they can get back out there, then you're going to need to go to advanced imaging to get them that answer. But for a lot of patients, repeat x-rays will be able to see in real time after injuries if you don't see it initially. Chronic injuries, chronic orthopedic injuries, again, x-rays are going to be your standard go-to pretty much all the time. Consider dynamic imaging when you're looking at specific anatomy, especially the spine. So a lot of people will make the mistake of only getting frontal and lateral views of the spine. You really need to get flexion extension views because that shows you the dynamic motion of the spine. Remember, we're all sports medicine doing sports medicine treatments. Motion is key. So static frontal and lateral views don't help as much as the dynamic flexion extension views. You can also do that with other areas. You can get leg lengths x-rays, so you can look at the mechanics of the pelvis all the way down through the feet. Now, if there's more concern of soft tissue injury, as I mentioned, MRI is going to be the way to go. Ultrasound can be done in certain cases, but it's really user dependent. For a shoulder, for example, that's really hard. Unless you're an expert at ultrasound, you're going to struggle seeing the dynamic and complex anatomy of the shoulder in real time. I'd encourage you to practice and learn it, but to do a full diagnosis on the shoulder, it's probably going to take you 30 to 45 minutes to do an ultrasound, which is, that's quite a bit of time for a single patient encounter. MRI is going to be a lot more sensitive and specific for pathology. Sometimes patients can undergo MRI, and that's when ultrasound becomes important. MRIs can be ordered with and without contrast. If you're suspecting malignancy, that's when you'll need contrast. If you're looking for infection, that also needs contrast. So those are some of the ones where you're definitely going to need contrast. Other imaging modalities for chronic orthopedic problems, a CT myelogram if you can't complete a spine MRI. So there's always alternatives. There's trade-offs with them, but there's alternatives. So if a patient can't undergo a spine MRI, then a CT myelogram is going to be your next best bet. There's SPECT CT, there's all type of other tricks in there, but again, CT myelogram will be next. Dynamic ultrasound when indicated, most facilities have limited experience. So if you are not doing it yourself and you order from a traditional radiology practice a dynamic ultrasound of the shoulder, they're probably going to call you and say, no, just order an MRI. Most of the time, that's what you're going to get. When I was in private practice before I came there, we had a traditional radiology practice, that's what they said, until I changed that opinion. But, again, if you're doing it yourself, then you're not only seeing the images, you're examining the patient in real time, and it's exceptionally valuable. Ultrasound for fluid collections, again, you can do dynamic maneuvers to see if it's a lump, a hematoma, or just a simple cyst collection. And then again, flexion extension views, motion, that's key when you're doing this with CT and ultrasound. This is a really cool scanner. We have not a lot of places have this yet. This is a standing CT scanner. We were the second in the United States to have this. I actually was the first human being that's got scanned in the scanner itself. I went to the company and scanned myself. So what this is a low dose radiation CT scan. So this CT scanner provides the same radiation dose as an X-ray, but you get full volumetric images from the pelvis down through the feet. So with this type of scanner now, with a patient standing, you can get all type of measurements that were not previously available. And we're still collecting data on this and looking at ways to use it. But what we've been using it a lot for recently is working with the podiatrists as well as PTs for orthotic fitting of patients. What we're finding is a lot of times, when you order orthotics for a patient, it's not actually correcting the problem that you anticipated. So we've had patients get orthotics and then we come back and rescan them, and they were only correcting the deformity by about 10-15%. So I started to have the PTs and orthosists come over and I would show them, I say, look, this is all that it's fixing. I said, you're not even close. And they were shocked to see that. So then they would use stiffer material, they would use different angles on their orthotics, and then we got the patient closer to the proper correction. So it's been really amazing to see what you can do scanning the patients with this new type of scanner. Again, low dose, similar to a handful of X-rays. So overall, safe for the information you're getting. Okay, let me pause there real quick, and then I'll get into some examples for imaging. Any questions on that so far?
Dr. McGinley, I had a question about the open MRI.
Mm-hmm.
It was the newer version 80 millimeters or centimeters? I forget which one.
Centimeters, yeah. So pretty much
Centimeters,
the size of a CT scanner, so fairly wide open. So the AP distance is actually greater than your quote-unquote open MRI scanner.
I imagine that might be better for patients who can't tolerate supine position or have a larger habitus, but have you personally used that, or has that been personally advantageous for you, for your patient population?
Yeah, in our clinical practice, we have the larger bore 80 centimeter scanner, but we were using previously another facility that had a traditional open scanner, and the image quality was just poor on those older open scanners compared to the new AI-driven, traditional setup of the scanner. So the image quality is in line with your standard 1.5 Tesla scanner. So that's not even comparable to your open scanners that you see elsewhere. The open scanners are hard to read, like you're squinting trying to see the anatomy a lot of times on those traditional open scanners. So these larger bore scanners really are a game changer for that, for patients that are claustrophobic or larger and can't fit into the traditional open scanner.
Great, thank you.
Good. Okay, so we'll get into a couple examples of cases and some unique things here along the way. So this is a patient finger dislocation. So this is a very simple one. 36-year-old came into ortho urgent care for right fifth digit pain and deformity when playing volleyball. Presented to urgent care and was referred to us for further evaluation. So again, the key here is X-ray. So we got the X-rays, and what you're looking for a number of things. One, you want to see exactly which joint is dislocated and in which direction. So we had 3 views of the fifth digit. Right fifth PIP joint dislocation, and what it told us, number one, was there was no fracture, so we didn't have comminuted fracture that we have to be concerned about with the reduction, and it showed us exactly where the bones were located, so we knew more precisely when we do the reduction that'll be done right the first time. So it's easier for the patient, safer for the patient. So very simple example of using X-ray to help you make a clinical decision on treating the patient and making sure that there's no other complications before you do that reduction. So knowing if there's a comminution of that joint space before you try to reduce it is important, because then those fragments can get sort of jammed up in that joint and cause further problems down the road. So this one showed us that there were no other fractures. It was very simple, and then we ended up doing the reduction and confirmed that everything was okay. So very simple example. This is the next one, a knee injury. So this patient came into our ortho urgent care for left knee pain and swelling. Began during a volleyball tournament. She felt a crunch in her knee and then had weakness. She quit playing at that time. Iced it, did all the conservative stuff, but it was becoming more stiff and numb inside. She had clicking and catching, swelling along the leg, and she only had the pain out of 2 out of 10. So we got X-rays. Again, that's going to be your first step. So initial X-rays, no fracture dislocation, joints were normal. She had a joint effusion, but everything else was normal. So, in that situation, what you don't want to get sort of blindsided by is saying, well, maybe she just tweaked it and got an effusion. There's nothing going on. We'll just let her go and tell her to rest and ice it. So for this one, because of the mechanism of injury, we ended up getting an MRI of this particular patient. And she had a complete tear of her ACL with a large joint effusion. So this is a T1 image, so it's not fluid sensitive. This is a bone sensitive. But the ACL would typically be a dark structure located between the femur and tibia on this sagittal image. And then you can sort of see the large joint effusion, the white area, up on this T1 image. She actually had a ruptured Baker cyst with fluid extending along the leg that was causing the pain, and then quite a bit of inflammation around that joint, a bone contusion of the femoral condyle, and then sprain of the MCL as well as the LCL. So an X-ray that only showed a joint effusion, which we can see on this T1 image, ended up being quite a bit of pathology within that knee. So just remember, just because an X-ray doesn't look too concerning, if you see a pretty big joint effusion in an otherwise healthy patient, be concerned that there's soft tissue problems within that knee. Your exam may also not be as positive as you think, because you're going to get contractures of the muscles, which are going to stabilize and protect that joint, and your testing, your exam findings may not be as abnormal as you would expect them to be based on the imaging because of the protective effect of the muscles surrounding the knee. So in this MRI, quite a bit of pathology. This patient ended up going to surgery for repair. Okay, so I'm going to get into a couple of cool things at this point. So our clinic is the official orthopedic partner for Pro Motocross. So we see a lot of crazy stuff along the way. This next one, we are the referral center worldwide for arm pumps, so essentially exertional compartment syndrome of the forearm. I developed and patented a procedure probably about 12 years ago to treat this through a minimally invasive approach. So pretty much most of the pros in the whole planet come to see us in Casper, Wyoming. So this one here, let me talk about it a little bit. It's a 22-year-old professional. He's on one of the pro teams. He was coming in for a treatment of arm pump. And, it's a fairly standard exertional compartment syndrome of the forearm. When he showed up in my office, he's like, "Hey, Doc, I wrecked last week in practice. I ended up racing this weekend, but my clavicle and shoulder were really sore. I previously broke it." He said, "Do you mind just taking a look at that while we're here?" So the key point is when a motocrosser says something hurts and he wants you to look at it, you better look. There's likely way more pathology than you think. So motocross and bull riders, those are the ones where if they show up in your office and you don't find something, that means you're probably missing something. So for this one, we took a look at his clavicle. This is his injury. So this is the video of his injury. Flying off the bike, okay? He got up and kept riding after that crash. So I'll play that again if you missed that. So he's coming over the jump, getting thrown off the bike, put his arm out, hit the ground. So on inspection, his anatomy looked fine. He had no tenderness to palpation of the elbows, forearms, and wrists. He had normal range of motion. He actually raced that night after that crash. He had tenderness to palpation of the distal left clavicle, so just a little bit. I could push on it pretty hard, and he was tolerating it pretty well. And just some soreness on the outside. So normal range of motion. Strength was 4 out of 5, but not too bad. So we got x-rays, and he had a previous fracture of that area. They did an interesting reconstruction with 2 plates, but they did a prior reconstruction. This is what it looked like. And I'd never seen this before. There's 2 plates. They're bent, so those are not contoured plates. He bent both of those plates. This one got bent 90 degrees. This one, almost 45 degrees. He raced an entire race and actually finished right around 12th place in top pro class in the world that weekend after re-breaking this clavicle. So you can see the clavicle break there, and then you can see this plate bent 90 degrees, and then this one bent about 45 degrees. So when I first got this x-ray, I asked him, I said, I was shocked to see 2 bent plates. I said, "Do you have any other x-rays of this?" and everything. He pulled up on his phone, and the plates were completely flat. So I was like, well, got some bad news for you here. I know you came in for arm pump, but we're going to have to get you to a surgeon and get this repaired. So he literally walked in like that, in no discomfort, just some minor discomfort, and it was like, "Hey, do you mind taking a look at this?" And that's what we ended up finding. We did a CT. Unfortunately, some of those screws are too long. One screw was directly on top of the subclavian vein. The tip of the screw was hitting the subclavian vein. He's lucky when he rebroke this that that screw didn't just tear right through the subclavian vein. So with the CT, we could see the break, we could see the hardware, everything was fine. He still wanted to get treated for arm pump because he's going to have some downtime when to go back. So we did the workup that we do for arm pump. We do a post-stress MRI where they do grip measurements, a grip dynamometer, and then we scan the patient pre and post grip stress imaging. So these are cross-sectional images through the forearm, fluid sensitive. So at rest, the black areas are the bones, radius and ulna. All the darker gray are the muscles, the flexor compartments, the larger area, extensor compartments, the sort of the smaller area to the right. And then we do grip dynamometer stress on the patient, and then we scan them again. Exactly the same scanning sequence, so everything that you see that lights up that's a little bit brighter, that's actual swelling or edema in the muscle. Traditional compartment pressure testing using needle compartment measures, I would encourage you to stop doing that. If you actually look at the data on that, most people, 95%, don't even follow the protocol correctly. And I did a test on this. I got a meat sample. I put one of those pressure devices, one of the Stryker pressure devices in it. And depending on ever so slightly, I'd push on the syringe. I can get numbers from 5, so normal, all the way up to 100 in the exact same position in the meat sample. So it's very subjective, and it's very subjective to bias within those studies. So the MRI protocol is non-biased. You scan them at rest, do the same protocol, and scan them afterwards. You can visually see the swelling within the muscle structures. This works for lower extremity as well as upper extremity. But in this one, he had arm pump. We then did a CTI angiogram to target the areas that were functionally compressing. So the veins open, and then when they did a grip stress test, the veins are no longer visible. So then we would target those muscles using botulinum toxin. We would inject botulinum toxin into those areas and treat those areas and allow the normalization of blood flow in this patient. We're a specialty referral center for this. We're pretty much the only ones doing it anywhere on the planet. This is what that looks like. It's done in the office in the outpatient setting. I use AR for all of my procedures. I have wireless ultrasound, so my machine's over here. I can see my image over the patient in real time with AR. This is one of the pro riders that came in that we were treating for arm pump. We're doing the injections right there in the comfort of our office. So we're very technology based. We're using pretty much all the latest technologies for all of these type of procedures. It's going to save my neck, so I won't be the subject of one of these conversations down the road. By having the AR, I can see the image comfortably over the area that we're working. Okay, I'm going to do 1 or 2 case studies, and then we'll open this up for questions. Jessica, if you're okay with that. Next is going to be ultrasound-guided trigger finger release of the thumb. So we are the first site to do this as well. So we have probably about 100 of these at this point. So this patient, 78-year-old, traditional symptoms of trigger finger. X-ray just shows some mild degenerative changes of the CMC joint. Ultrasound shows stenosing tenosynovitis of the left thumb. Basic supplies for this procedure: patient positioning to ensure advancement of the device. So very simple setup to do a release on the thumb for TFR. The device with the little purple button on it, that's the Sonix TFR device. They developed it for the 2nd through 5th fingers. We were the first to do it for the thumb. Like I said, we have the highest volume of that as well. My AR system, I've been doing this, probably using this for about 10 years now. Again, probably one of the first sites around doing that. Allows me in a comfortable position, especially for these very technical procedures, to make sure that we can see the anatomy. For the thumb, the main risk with this procedure is the radial digital nerve branch, and the red arrow points to that black circle. That's the nerve, and then the sort of the larger circle below it, that's the flexor tendon. So that nerve comes across from ulnar to the radial side of the thumb. You have to make sure when you put this device in that you don't cut that nerve. That's the reason Sonix didn't get FDA clearance for their device for the thumb, because they were afraid too many people would miss that nerve and cut it. So you have to make sure you identify that nerve before you do this procedure. So we did the pre-procedure ultrasound. It's fairly obvious when I have a red arrow pointing to it, so you can see it fairly clearly. And then there's the flexor tendon underneath. I'm using the wireless ultrasound in a sterile setting. I have a mark along where I'm going to be placing the device, which is just distal. So I usually make my mark right where the nerve is, because when I come in with the device, I'm going to be distal to it. So I use the nerve as my skin marking point when I'm placing the device for this procedure. We then will numb up the skin. You can see the needle coming into the flexor tendon sheath, so a 27 gauge needle. We're going to numb it up with some lidocaine to place the device. I make a tiny incision in the skin, and then I'm going to slide the TFR device through that entry point and along the tendon sheath under the A1 pulley. Once I get it under the pulley, I'm going to advance the cutting blade. You can see that sliding along the device under the A1 pulley. Once I get it under, I'll deploy that blade, make a small cut in the A1 pulley, and then release it. So that's what that looks like in real time. Oh, sorry, I went backwards there. We'll then confirm that the pulley's cut, so now I'm wiggling my device back and forth and it moves freely, so I know the A1 pulley's been transected. You can see the nerve off to the side, completely intact at that point. Typically one pass, occasionally two passes. Same company makes a device for carpal tunnel release. We're one of the centers of excellence, one of the 10 centers of excellence for this around the country. These are the incisions, what they look like for that afterwards. You can barely see it. I got to put a circle around it. Usually patients can go back to work in 3 to 4 days. We have a published paper on looking at the recovery time using MRI. Very simple device. You slide it under the transverse carpal ligament with ultrasound. You'll deploy the cutting blade. You're watching the entire time. The balloons will deploy out and remove and displace the critical anatomy. This takes me on average 3 to 5 minutes to do a carpal tunnel release, no stitches, wide awake. My patients go back to work within 3 days after the procedure, and their scar, you can barely see it after a week after the procedure. We've done over 1,000 of these to date. Other things that we do in our clinic that we can talk about at a later time. I do PRP and stem cells all the time. I probably did 5 stem cell procedures today and 3 PRP today. Steroids we do, but I don't like to use them. They're very corrosive on soft tissue. They do result in degeneration of tissue. They have a role in acute inflammatory processes, but I wouldn't use steroids as my main treatment option for patients. So stem cells and PRP fix the problem. They're healing the tissue. They're treating the tissue. Steroids are more anti-inflammatory. They're fixing a symptom, essentially. So that red line is symptom versus problem treatment. We focus on problem treatment, but in some cases steroids are necessary. Sometimes they are beneficial depending on how you use them, and we will use them if that's what the patient chooses. In the end, they can choose what they like. We can make the recommendations, but it's up to the patient to decide what they want. We partner with a lot of sports organizations. As I said, nationally, we're part of the Pro Motocross and now IndyCar with Andretti Racing. Locally, we partner pretty much with all these sports teams, and it's really fun to see the diversity of the sports coming into our facility and being able to get them back out there without surgery. And again, going through medicine, right, do no harm, that's our creed. Surgery is harm, so if you could do something less invasively, you want to try that first. You want surgery to be your last option. Once you have surgery, you can't go backwards. So you want to start with physical therapy, you want to start with the basics. Once you go from there, that's where you get into the injectable procedures, then you get into the minimally invasive procedures, and only after you fail all those really should surgery be the deciding point or option. So you want to exhaust all the conservative options first before you get to that. So I'll stop there. If you have any questions on this, I'll spend as much time as we need, Jessica, to answer any questions. But let me stop there. I'll stop sharing this screen, and we'll see what questions come up. You can always visit my website for more information on our procedures. We have a lot of videos on a lot of procedures, as well as the partners that we work with. If you're a fan of motocross, I'm on the SMX Insider podcast every week. I go over the injuries that occurred that Saturday for the pro racers as they're out there racing. So that's always fun. It's a whole different group. It's always great to chat with them and see how they are taken care of versus other athletes. It really, what they can tolerate and race with is astounding to me. But all right, I'll stop there, Jessica, see if there's any questions.
You just answered my question. I was curious what types of injuries you see commonly, but I'll definitely check that out. SMX Insider, you said?
Yeah, SMX Insider podcast. I have a health segment on there each week, so it's a 30-minute podcast for Pro Motocross. So they do the updates for the racing that past week for all the pros, and then I'll come on and discuss, for a few minutes, we'll discuss the injuries, and we'll go over that as best we can. So yeah, it's really fun. Again, I learn as well from how they recover and some of the ways that they get around this, but yeah, it's great to see.
Awesome, thank you. I dropped it in the chat for everyone. I'll open it up to questions now. I see Matthew's comment. Matthew says beast. I think that was around the time of the trigger finger release when he commented that.
Yeah, we have several firsts on procedures. So I was the first one to do the trigger thumb, not trigger finger. I think we were third on the trigger finger with that device, but we were first on the thumb. And it was because of that nerve. A lot of individuals were not confident finding that digital radial branch, and it looked fairly obvious to me, so we went ahead and did it. I've developed a lot of procedures using 10x. If you're familiar with 10x, it's a needle that vibrates at a high frequency, aspirates out. So I've developed a procedure to release Dupuytren's contracture. So I've probably done about 60 of those at this point. Releasing Dupuytren's contracture using 10x, so saves them from a big surgery. We did the thumb. We've done several other procedures as first and only. We do decompressions for subacromial impingement using 10x. I also use the MyEye scope to see what's happening as I'm doing the procedure. So we'll come in through the scope port with the needle with the MyEye, and then I'll place the 10x in the subacromial space. We'll take down the coracoacromial ligament and relieve the subacromial impingement. So that's just a small cross section, but it's fun being able to do that. That looks like another question there, Jessica.
Yeah, so Matthew's asking, do you ever host or teach these procedures at conferences or CME related events?
Yeah, so we have a conference each year that is specific to this. It's typically in September. I think it's posted on our website. We have faculty from various specialties. So we have orthopedic surgery, we have PM&R, we have chiropractor occasionally, we have radiology. We have primary care, sports medicine. So I bring in faculty so you get perspective from various different specialties because my opinion sometimes is different than someone else's. So we bring that together to formulate those questions. And we do it once a year. We host it once a year. And we focus on these interventional procedures. So really the cutting edge technologies procedures. We cover the basics, but really we get into the unique procedures. That will be in Casper, Wyoming in September. We do this on occasion at other locations, but that core group of faculty, it's usually once a year. We have people rotate out with us. We have a fellowship, so we have a 6-month and a year-long interventional fellowship at our facility for MSK intervention. So that's also available. And then, if you come out for smaller rotations, we offer, single day, week, 2 weeks, depending on what you want out of those rotations. So I have students out with me all the time. It's not uncommon. I do summer internships for research students. I'm involved academically quite a bit. We still publish on a routine basis. Yeah, I know sometimes that's a lot to digest. A lot of this stuff's unique. I'd encourage you to go to our website and take a look at some of this. We have presentations and publications that are out there to review some of the data. I collect data on every single procedure I do, whether it's a single corticosteroid injection or these advanced procedures. I collect data on every single patient encounter. We do minimum follow-ups for tracking for at least 1 year. For the more complex procedures, we follow the patients for 2 to 3 years afterwards. So we have thousands and thousands of data points on all of these procedures, and it's really great because you can tell right away when one technique is working versus another, and allows you to pivot and change your technique if you can recognize it through pattern recognition early on.
Another question, Dr. McGinley, is the information about the CME conferences and rotations able to be found on your website?
Yes.
Okay. You have quite a few websites. Do you mind directing me towards which one the rotations one is on, or how I can?
Yeah, good question. So if McGinley Education Innovations would have it, the McGinley Clinic should have it as well. I don't obviously manage our sites and stuff like that, but I know it's out there. If you put in the annual course, if you give me a second, I could probably just look it up.
I think I found it. Can you confirm that's the right one? McGinleyinnovations.com/medical education.
That's it. Yeah.
Perfect.
Yeah, and like I said, our faculty are fairly unique. My mentor, Dr. Sandeep Biswal, he's a musculoskeletal radiologist. He's at in Madison, University of Wisconsin in Madison. And really cool thing he developed is pain imaging, which sounds insane, but I've sent several patients there that I couldn't figure out the problem. And he would send me back these incredible images, and it's like, it's right there. And it would be muscles like I didn't even hear of. So I didn't even know that muscle existed. But it's pretty impressive imaging. He developed that when he was back at Stanford. When I was back there, he was my mentor, and they went to Wisconsin. But if you look up what he's doing in pain imaging, he's using essentially a PET MRI with a specific radio tracer, and it literally will highlight the part that's firing with inflammation and pain. So for sciatica, for example, instead of guessing along the pathway where the pain's coming from, it'll show you exactly where it's coming from. So it's very impressive. And then we have other faculty in the various specialties that are highly published and unique in their perspective. The orthopedic surgeon that worked with us trained with Dr. Andrews on sports medicine. So we have the full range of individuals of qualities and backgrounds.
Well, before we wrap, Dr. McGinley, I want to express how grateful we are to have you as our distinguished speaker tonight. This was an incredible presentation. And I want to thank everyone, all the AMSSM members who attended tonight. It's been my pleasure serving as moderator. If there aren't any other questions, I'd like to thank everyone who attended. Thank you, Dr. McGinley, again.
Yeah, I appreciate that, Jessica. And if other questions come up, again, this is a pretty broad topic we've covered, but if there's interest on interventional procedures or more in depth on imaging or things like that, I'd be happy to sort of titrate out specific packages of educational segments. I have a vast number of images and procedures that we can talk about. This was more of a 20,000 foot overview of quite a bit of new information. But yeah, if there's interest from the membership and students, I'm always glad to volunteer and help as best I can.
Wonderful. Well, thank you so much.
All right. Well, thanks, everyone. Appreciate you joining tonight. And Jessica, thanks for hosting and having me as part of this program. And hopefully,
happy to.
Fun here found it helpful.
Have a great night, everyone. Thank you.
Thank you.